Good evening, everyone. Thank you for joining us this evening. My name is Craig Gluckman. I'm a clinical instructor of medicine and a gastroenterologist in the Division of Digestive Diseases here at UCLA. I'm also a member of the UCLA Robert G. Kardashian Center for Esophageal Health. I'm very excited to be presenting as part of our Esophageal Insight Zoom series. We've had some great talks in recent months, and we've got some exciting talks coming up, so I encourage all of you to look out for these. I've been tasked with talking about supragastric belching. It should take less than 30 minutes, and then I'd like to hand over to my colleague Lisa Bolden from the Department of Audiology and Speech Pathology to talk about some exciting new developments in the management of supragastric belching. Belching is really common. It's reported in up to 50% of the general population with dyspeptic symptoms. We know that over 20% of these patients experience at least moderate to severe interference with daily activities of daily living. From a study by Bredenhart et al. In 2010, they found that patients with excessive belching have significantly impaired health-related quality of life. To this point, they had reduced social functioning, worsening mental health, reduced vitality, decrease in general health, as well as bodily pain. So clearly, belching is really common. But how common is it? This is the UCLA esophageal website where we've divided up based on the number of clicks represented by visits to each of our pages represented on our esophageal website. And you could see from the month of September, the most commonly clicked on site that patients are reading about is belching. And I believe belching has been the most commonly clicked site for the past few months, or at least for as long as we've been recording. The second most commonly clicked topic is globus, and the third is jackhammer's esophagus. And you'll notice as a gastroenterologist, these are kind of three difficult conditions to treat. If you go down, make an appointment is all the way down in almost the 20th position. And we're hoping with more awareness, patients will be clicking more, making more appointments, being assessed by their gastroenterologist, because there is plenty that we can do for belching, and we understand way more about this disease. So the first belch that I'm going to speak about is the so-called gastric belch. We all do it. Some do it more than others, hence, the belching Olympics. It is purely a physiologic phenomenon. It is totally involuntary. Some people feel that they can voluntarily control a belch. You can't. A gastric belch is totally involuntary. If you are able to voluntarily control it, it's most likely not a gastric belch. We know that it can happen up to 30 times a day, sometimes less, sometimes more. And it is purely a reflex-mediated phenomenon. Reflex rather than reflux. There are two reflexes that need to occur in order for a gastric belch to happen. The first is relaxation of the lower esophageal sphincter, and the second is relaxation of the upper esophageal sphincter. The gastric belch is purely a venting mechanism to vent air from the stomach. And as I said, some do it more than others. So this is a cartoon depicting a gastric belch. And if you can see in picture A, the stomach is full of intragastric air. And this intragastric air results in what is known as a transient lower esophageal sphincter relaxation. The lower esophageal sphincter represented here transiently opens, and we get an outflow of air from the stomach up through the distal esophagus. At this point, the upper esophageal sphincter is closed, and this is where the second reflex occurs. It immediately, the upper esophageal sphincter relaxes, and with the pressure increase in the proximal esophagus, air is pushed out the esophagus into the mouth and pharynx, and this is perceived as a gastric belch. So in the last 20 or 30 years, there's been major advances in technology that we're able to use to evaluate conditions of the esophagus. So much so that high-resolution esophageal manometry that was originally used to evaluate dysphagia has multiple other uses other than the evaluation of dysphagia, and I'll show you as we go along in this talk. For those of you that don't use high-resolution esophageal manometry that often, I'll talk you through these beautiful images that we are able to visualize. On the y-axis, we can see the pressure. Higher pressures have harder colors like purple and red. Lower pressures, represented below, are more of the softer colors, the blues and the greens. And on the x-axis, we have time. So this is a normal high-resolution esophageal manometry of a swallow. We can see at the top, we have the upper esophageal sphincter, and at the bottom, the lower esophageal sphincter. This star represents opening of the upper esophagus, of the upper esophageal sphincter, which is very important when we need to swallow a liquid or solid bolus. The esophagus is divided into two parts. The proximal 1/3 is striated muscle. The distal 2/3 is smooth muscle. And there is this transition zone between the 2 points. Here is the lower esophageal sphincter opening, and this is very important to allow liquids and solids to move from the esophagus into the stomach. So this is a normal swallow as witnessed on an esophageal manometry. The second major advance in esophageal analysis and studying is the multi-channel intraluminal impedance pH catheter. This is a flexible catheter. It has multiple impedance sensors all the way along the length of the catheter, placed at 2 centimeters apart. And these sensors measure impedance. There are also 2 sensors which measure esophageal as well as gastric pH. And it's very important during the placement of an impedance catheter that you're able to cross the lower esophageal sphincter. The impedance pH catheter makes use of Ohm's law, in that we know that impedance is inversely proportional to conductivity of the electricity through a medium. So we know those substances like liquids with a low impedance have high conductivity, and contrast that with air or gas, which has high impedance, has low conductivity. So if you look at the image on the right, excuse me, these represent the 2 pH sensors. This one is in the distal esophagus, and this one is in the distal stomach. And you can clearly see that this is an acid reflux event with the pH predominantly below 4, both in the distal esophagus and the stomach. This is the impedance portion of the analysis, and we can see that there is retrograde movement of a liquid reflux episode from the distal esophagus in a retrograde manner up the esophagus towards the proximal area of the esophagus. We can see that there is a reduction in impedance as evidenced by a drop in the baseline, which is consistent with a liquid acid reflux event. So if you place the line tracing of pH impedance on the background of a high resolution manometry, this is what the gastric belch looks like. We have our transient lower esophageal relaxation. We have movement of gas or air in a retrograde fashion up the esophagus. And we can see that air or gas results in an increase in impedance, as evidenced by an increase in impedance on the line tracing. So this is a gastric belch. If you place a gastric belch alongside an acid reflux, you can see that the 2 events are pretty similar, except for one major difference. Both events have a transient lower esophageal sphincter relaxation, but the major difference with the reflux episode is that you have liquid moving up the esophagus, and liquid is represented by a decrease in the impedance, whereas air or gas results in an increase in impedance. You can see immediately after this reflux episode, there was a swallow to relieve the reflux from the esophagus. And you can see the concurrent drop in the pH occurred at the same time as this acid reflux episode. So with these new diagnostic modalities, we were able to describe and diagnose a so-called new belch, the supragastric belch. The reason we call it supragastric is everything is happening above the stomach. So if you look at a cartoon representation, the first event or the first mechanism within the supragastric belch is diaphragmatic contraction. This moves the diaphragm down and results in a negative pressure or a decreased pressure in the esophagus. The LES remains closed throughout the supragastric belch. There is negative pressure in the proximal esophagus, and this is lower than the atmospheric pressure or the pressure within the pharynx. And this results in air moving through the relaxed UES from the higher pressure in the pharynx to the lower pressure in the esophagus. And you can see the movement of air down the esophagus through the opened UES. It reaches the lower esophageal sphincter, which remains closed, and it is immediately pushed up the esophagus through the open UES and out through the mouth. And this is what the patient perceives as a supragastric belch. So there are two mechanisms of supragastric belching. The first mechanism is so-called air inhalation. And you can see that the lower esophageal sphincter remains closed throughout the supragastric belch. There is a differential in pressure. There is a reduction in pressure in the esophagus. So air is almost sucked or inhaled into the esophagus. It reaches the lower esophageal sphincter, which is closed, and it is almost immediately pushed back up out the esophagus from where it came and out through the mouth. Once again, you can see on the line tracing the direction of airflow, initially antegrade and then retrograde, and air results in an increase in impedance as evidenced by the increase impedance on the line tracing. It is not a swallow. There is no pharyngeal peristalsis. There is no esophageal peristalsis. And as I said, the lower esophageal sphincter remains closed throughout. The second mechanism for supragastric belch is through air injection. Once again, the lower esophageal sphincter remains closed. There is relaxation of the UES. The patient will tensely close their lips. There is vertical laryngeal movements with increased pressure within the pharynx. Air is moved down the esophagus. It reaches the closed lower esophageal sphincter, and once again, it immediately moves back up out the esophagus from where it came from. Once again, it's not a swallow. It's injection of air into the esophagus, reaches the lower esophageal sphincter, and then back out the esophagus through the mouth. So if you put the two mechanisms of a supragastric belch side by side, you can see at the top, the differential in pressure results in air being inhaled into the esophagus. These are the so-called air suckers. The second mechanism is simultaneous pressure increase in the pharynx, and this results in the so-called air pushing, air injection, and this is the second mechanism of supragastric belch. Contrast these two with the true swallow, where you get pharyngeal peristalsis with an upward motion of the UES. In belching or supragastric belching, there is no pharyngeal or esophageal contraction or peristalsis. And once again, if you look at these two belches side by side, you can see with the gastric belch, there is a retrograde movement of air distally to the proximal with an increase in impedance. And you can contrast that with a supragastric belch where air moves anterograde. There is increase in impedance. It reaches the closed lower esophageal sphincter and then retrogradely moves from distally to proximally up out the esophagus and out through the mouth. So once again, air is not swallowed. There is no esophageal peristalsis, and air doesn't reach or leave the stomach, hence supragastric belch. Everything happens above the stomach. So what else do we know about supragastric belching? Initially, we believe that the patient does these supragastric belches to relieve some sort of uncomfortable GI sensation. In this image, the patient has a reflux episode, and in order to relieve that uncomfortable acid reflux, he produces a supragastric belch. We know that these episodes are purely voluntary to begin with, but after a period of time, these episodes become totally out of control, almost a behavioral or learned disorder. And the patient actually forgets that these episodes were under voluntary control to begin with. It can happen almost hundreds of times per day. In this study, these patients had between 17 and 510 supragastric belching episodes per a 24-hour period. So clearly you can see it happens far out of proportion, and it can really affect a patient's quality of life. We know that a supragastric belch does not occur during speech, and nor does it occur during singing. We've all had patients who've come into our office, and while they're speaking to us, they don't supragastric belch. But the minute we start speaking to them, they supragastric belch away. So clearly it's lessened with distraction. And to emphasize that, look what happens when a patient is sleeping. This is supragastric belching impedance tracing when they're awake. You can see all this activity during waking hours. But when the patient goes to sleep, there's no supragastric belching episodes. Everything is quiet. So clearly, supragastric belching episodes are lessened with distraction, and they don't occur during sleep. But this is the classic chicken and the egg scenario. Does the supragastric belch cause acid reflux? Or is it the acid reflux that leads to a supragastric belch? We know that between 40 and 50% of patients with acid reflux will belch. But we know that far predominantly, these patients will have supragastric belches rather than gastric belches. We know that PPIs help with acid reflux, but we're not sure if they improve supragastric belching. And there are numerous questions that are yet answered. Does the belch induce the reflux episode? Does the belch actually relieve the reflux episode? And does the acid reflux actually cause the belch? So once again, looking at these two scenarios side by side, and by the end of this talk, you're going to be experts in interpreting impedance line tracing. You can see with the first scenario, the supragastric belch follows the acid reflux episode. So you can almost presume that this supragastric belch caused an acid reflux episode. Compare that with this. There's a drop in pH, there's an acid reflux episode, and that's immediately followed by the supragastric belch, almost like a way that the patient can relieve the discomfort of acid reflux by supragastric belch. So this was an excellent study. It looked at supragastric belching, and it wanted to talk about prevalence and association with acid reflux and esophageal hypomotility. So what did they do? They took 40 healthy volunteers. These were healthy people. They all underwent 24-hour pH impedance studies together with high-resolution esophageal manometry. They were totally asymptomatic. They had no acid reflux. Within these normal healthy volunteers, between 0 to 15 episodes of supragastric belching happened in these healthy asymptomatic volunteers. The authors of the study determined that more than 13 was significant at the 95th percentile, and therefore any patient with more than 13 supragastric belching was regarded as excessive. So what did they do? They looked at 2,950 patients over a 3-year period, and 100 of those patients had excessive supragastric belching. This gives a prevalence of 3.4% in their cohort. The 100 patients makes the math really easy. 95% or 95 out of 100 had typical acid reflux symptoms. 86% of those, 86 out of the 100, actually reported excessive belching. So that means 14% didn't report excessive belching as a predominant complaint. But what's most interesting in the study is that only 5% of people had supragastric belching in isolation. So 95% of people had some sort of dyspepsia, acid reflux, bloating, something else that went side by side their supragastric belching, but only 5 out of 100 actually had the belching in isolation. So what were the results? Patients with acid reflux and increased acid exposure had way more supragastric belching episodes than patients with normal acid exposure. And you could see that here, a supragastric belch is immediately followed within 1 second by an acid reflux episode. The other significant finding from the study was that patients with hypomotility or dysmotility had significantly increased supragastric belching episodes than those patients with normal motility. You can see that those patients with dysmotility had significantly increasing supragastric belching episodes within 24 hours. So clearly, dysmotility and acid reflux is more likelihood to occur in patients with supragastric belching. So we can diagnose supragastric belching, but how do we treat it? Baclofen as a medication has been tried. There was one study which looked at baclofen. It was a study that looked at 12 patients. They all received 10 milligrams of baclofen 3 times a day. And we know that baclofen is a GABA beta agonist. And its mechanism in treating belching is by decreasing transient low esophageal reflux events. But we know that patients with supragastric belching do not have transient low esophageal reflux episodes. So we have to think that there's some sort of placebo effect in these patients. So in the study, you can see that there was far improvement in supragastric belching in those patients who took baclofen, contrasting those patients who never took baclofen. But once again, patients with supragastric belching, they do not have these TL-ESRs, so potentially we're dealing with a placebo effect. Also, when looking at baclofen, if anyone's trying to prescribe it, it's a really difficult medication for a patient to tolerate. There are many prohibitive side effects, including sedation and fatigue. So it's really difficult for a patient to be on baclofen. But really from the study, the evidence for baclofen in treating supragastric belching is weak. There was another case report where they looked at one patient who had an improvement in supragastric belching with the combination of pregabalin or Lyrica and baclofen. But really, when only looking at one patient, it's really difficult to make any meaningful conclusion. So when looking at treatment for supragastric belching, the evidence for baclofen is really weak. There are other therapeutic modalities we have in our armamentarium, including behavioral therapy through a psychologist. Another way we can potentially treat patients is by using abdominal or diaphragmatic breathing exercises. This can be easily taught through an app or an online video where patient actually concentrates on breathing through their stomach rather than through the chest, and potentially by a distraction, supragastric belching episodes may be far less. And lastly, and this is a perfect segue into speech therapy as a new and exciting treatment modality for patients with supragastric belching. And I'd like to hand over to my colleague, Lisa Bolden, who's going to present some exciting work from her group when using speech therapy for the treatment of supragastric belching. Lisa.
Thank you, Craig. And we're all set over. Good. So you're probably wondering, why is a speech pathologist talking about belching? Well, for decades, speech pathologists have taught patients actually how to produce a supragastric belch. You heard it right. We call that esophageal speech, and that was one of the tools that we offered to patients following laryngectomy. So the thinking goes, if a speech pathologist can teach a patient with a laryngectomy to produce a supragastric belch to talk, then the speech pathologist can teach a patient to not produce a supragastric belch. So let's take a look at what the literature says, the therapy gems that we gleaned from the literature, and then we'll share with you the case studies that we've had to date here at UCLA. So the first study is out of the Netherlands in 2010, and this is really exciting because this is new therapy and a new service that we can offer to our patients. It was one speech pathologist treating 11 patients. She saw each patient for 8 to 10 sessions, taught the difference between a gastric and a supragastric belch, increased the patient's awareness of preceding symptoms and what they were doing to take the air in, taught breathing exercises, taught speech exercises, helped the patients generalize. Her results on a visual analog scale, and right here is where you get a teaser alert. We will look at that shortly. 6 of her 11 patients reported a major reduction in supragastric belching. 4 out of 11 reported a minor improvement, and this was an interesting one. 1 out of 11 reported worsening supragastric belching. So we jump forward. There are no other papers until 2017, and we go to Singapore. Again, a speech pathologist there treated 36 patients, 4 sessions, taught a simplified version, just gastric versus supragastric belching and breathing. Out of the patients, 20 of 36 reported a 50% or more reduction in supragastric belching. They also reported less regurgitation and improved quality of life. These researchers followed up with their patients 4 months later and found that while there was a slight decrease in success since stopping therapy, that most of them were able to maintain enough control. Then we jump forward to 2018, Royal Hospital of London, and the cognitive behavioral therapists started treating patients. They saw 31 patients, 5 sessions each. They taught again gastric versus supragastric belching, triggering events, warning signals, and preventative exercises. Their results on the visual analog scale that you'll see shortly, 16 out of 31 reported a 50% or more improvement. And what's more, on manometry, they found that acid exposure time reduced. Back to the speech pathologists, same year, back to the Netherlands. By now, they've had 10 years of practice doing this. They've seen 48 patients, 10 sessions each, and the same protocol as before. This time, when looking at the visual analog scale, 40 out of 48 patients either had major or moderate reduction in symptoms. The cognitive behavioral therapists then the next year, back in London, put out another paper talking about what happened 6 to 12 months post-therapy. They found that those with less severe symptoms, less severe supragastric belching to start, had better outcome overall. They found that those with lower hypervigilance. Hypervigilance is what I like to call the princess and the pea syndrome. If you put a pea under the mattress, will the princess feel it? If you feel it, that is considered more hypervigilance, someone who is much more sensitive to how it feels, to a discomfort, okay? They tended to have not as good of an outcome. And those who had strong scores on cognitive behavioral therapy, meaning those who bought into therapy, those who believed the difference, those who were willing to do the exercises, did better. So if you take all the therapy and you combine it together, whether it's from a speech pathologist or a cognitive behavioral therapist, you'll see that there's a 50 to 80% rate of success. And what's more, the success is ongoing. So that's good news for our patients. So at UCLA, we developed our program around what we considered the best and what we read. We have 4 steps. Step 1, differentiating the gastric belch versus the supragastric belch. Step 2, increasing self-awareness for triggers, preceding physical sensations, and then air influx. We teach rescue breathing, which we'll show you in a minute, and then real-world application. So again, the gastric belch. This is a reflex, and it serves to vent the stomach, versus the supragastric belch, which is not a reflex and does not vent the stomach. No air enters the stomach and no air leaves the stomach. All air movement is from the oropharynx through the UES and right back out through the oropharynx. When patients understand this, they have their first aha moment. These are different belches. And oftentimes patients will tell me, yes, I have two belches. One is this really deep, big belch, and the other ones are these little baby belches. And the baby belches are the supragastric belches. The hallmark is fast and frequent belching. The belch is completed within 1 second, and it's considered a single episode if the supragastric belches are less than 5 seconds apart. Keep in mind, in severe cases, people can belch over 500 times a day. As you heard from Dr. Gluckman, there are 2 methods to relax the UES. Both result in airflow from the pharynx into the esophagus with immediate expulsion upon straining, injection and inhalation, and we'll review for a minute. Supragastric belch via injection, the tense labial closure with vertical laryngeal movements and simultaneous base of tongue and pharyngeal contraction. Teaser alert 2. You're going to see a video of this in a minute, and this is by far the less common of the 2 methods. The second method is supragastric belch via inhalation, which is deep, high thoracic inspiration with tight glottal closure, and the air is sucked in. We teach awareness of triggers. Is it positional? Is it eating food? Is it lifting weights? We teach self-awareness of preceding GI sensations. Often patients will complain of pressure building up in their chest or bloating in the stomach. We teach awareness of injection or inhalation. What are they doing to get the air in? We use mirrors, we videotape patients, and we provide reassurance that this is an attempt to alleviate a symptom of discomfort. When patients see how they take air in, whether it's injection or inhalation, that's when they have their second aha moment. I am doing that. Then we teach rescue breathing, step 3. So rescue breathing is really simple. We want to replace a behavior that calls attention to the person with a behavior that does not. We normalize behavior. So we simply teach patients to place their tongue on the roof of the mouth right at the alveolar ridge, the bony ridge right behind the 2 front teeth. They keep their lips slightly parted. I call it just resting happy face, like a resting smile. We focus attention on the ribs and abdomen. We focus on fully filling with air, fully emptying air, and we may even put the patient on a count of breathing to help them get the timing right. This is when the patient has the third aha moment. I'm not belching. And then we do what speech pathologists do best. We develop a hierarchy of situations, we plan and rehearse, and we send them out to apply their new skills in the real world. And this is when the patient has their fourth aha moment. I can control this. So it might be a little bit hard to see on the screen, so I'll read it to you, but this is the visual analog scale we use. It has 5 components, and it's taken from the research studies that we read about. Most of them had 4 to 6, and these were the 5 that resonated with us the most. The first one, and I'm going to read them. You may choose any number, 0 to 100, to describe. Question 1, how bothering do you experience your symptoms of excessive belching? 0 would be none, 25 a little, 50 somewhat, 75 to a great extent, and 100 to a very great extent. How bothering do you think your environment or others experience your excessive belching? Does excessive belching hamper your work or daily activities? Are your social activities hampered by excessive belching? And do you experience any level of control over your excessive belching? And on this one, the 0 to 100 is reversed. 0 means you have a very great control over the belching, and 100 means none. Okay, cases to date. We started offering this therapy last year, and it's been very exciting because we have had 12 cases to date so far. 5 have successfully completed treatment, 5 are in treatment, and 2 discontinued. And full disclosure, 1 discontinued because of financial difficulty, not in paying for services, but was unwilling to leave work to come in for treatment. And 1 discontinued because he really just was very angry and wanted to come in and yell. And unfortunately, we just weren't able to get past that. So case study number 1, 63-year-old female. Her onset of supragastric belching was while she was driving. It was following the euthanization of her beloved dog and a few weeks before her ovarian surgery. And I'm going to flip it to Dr. Gluckman to talk about her test results.
So thanks, Lisa. This is the report from a high-resolution esophageal manometry, and it was done with viscous and solid swallows. You can see that the median IRP was elevated at 18.5. Normal IRP is less than 15. The IRP is a measurement of resistance to the outflow at the LES. So her IRP of 18.5 suggested possible EGJ outflow obstruction. However, when sitting or upright with saline swallows, it normalized to 14.6, suggesting that the IRP was not significant to begin with. There was also increased intrabolus pressurization within a hiatal hernia. There were more frequent ineffective and failed swallows as the esophagus was challenged. So this goes to the point of esophageal dysmotility or hypomotility that I spoke about in my previous study. She had a 2-centimeter hiatal hernia, which may or may not have led her to have acid reflux, which was the second major association with supragastric belching. And during her belching episodes, there was repetitive and rapid belching behavior that was most similar to her supragastric belching. So this is a representation. At the bottom, you can see the lower esophageal sphincter remains closed throughout. She has these repetitive episodes of sucking air or inhaling air into the esophagus and immediately pushing her back out the esophagus. And you can see this happens multiple times over many seconds. So this was suggestive of supragastric belching.
And we have a video here of our patient, and you'll see, notice her base of tongue. You can see it under her chin, and notice her laryngeal movement. And this is our patient after treatment.
Approximately 1.5 years now, that has been gradually subsiding with treatment. I'm substantially improved at this point. It's gone from barely tolerable to very tolerable and no longer has a significant effect on my everyday life.
Case study 2, 28-year-old male with reflux and ineffective esophageal motor function. 5 therapy sessions, VAS before 350, VAS after 25. Case study 3, a 26-year-old male with reflux and minor esophageal motility disorder. 3 sessions, VAS before 235, VAS after 19. Case study 4, a 36-year-old transgender male with reflux and ineffective esophageal motility. 3 sessions, VAS before 215, VAS after 35. Case study 5,
a 57-year-old male with a small hiatal hernia. VAS before, 450. VAS after, 80. And stay tuned, we have more information coming on our other cases.
So the takeaway from all of this is we have the tools to help. Thank you so much.